Hi everyone, welcome to the Jobskin webinar series for compression and the management of multi-trauma. With us today is Veronica Eichmann, our clinical representative from New Zealand, as well as Rosemary Kendall, our presenter for the day. With that, I'll pass over to Rosemary.
Thanks, Adam. This is the second running of our webinar today, so might be a bit more efficient, you never know. And so today we're going to be looking at compression in the management of multi-trauma, and it's a fairly loose definition of multi-trauma because multi-trauma comes in all sorts of forms. And I think it's one of those areas that's very challenging for us as clinicians because not only there's so much variation from what you could call the norm. So there's certainly changes in structure, anatomical structure and body proportion, but also there may also be amputations, defects, free flaps, stomas, catheters, the whole external fixation, a whole lot of things to work around. And so that impacts the shape of the garment, the composition of the garment, but also how we anchor it, how it can be put on or taken off, and how well it conforms. So there's a whole lot of factors that come into play. Now, so the way we're going to run this now is that we're going to look at four main areas, really. First of all, there's going to be a fairly loose definition of multi-trauma. It's definitely not a academically rigorous definition of multi-trauma, but for us as clinicians, what are we talking about today? We're going to have a very, very quick just review of what it is that compression does and to look at how that impacts the multi-trauma patient. Brief covering of the practical, actually not so brief this part, about looking at the practical realities of measuring a multi-trauma patient. And then we've got a series of case studies. They're not all big multi-trauma patients or case studies, but I've chosen them because they can give us kind of little bits of information that we can all kind of pull together when we're seeing someone who has suffered a multi-trauma injury. So let's now, very quick overview. This is compression 101. Generally, compression is used, medical grade compression is used for treatment of vascular conditions, for lymphedema, range of edemas, dependent traumatic, certainly palliative edema. Compression is also used for scar management, both for hypertrophic and keloid scarring, for tissue shaping, postural support and correction, and for sensory stimulation. So there's a whole lot of things that can be achieved through compression. And the aims of compression specifically include reducing the formation of excess fluid in interstitial spaces, increasing the total pressure to encourage reabsorption and thereby reduce edema, reduce dilated vessels, particularly veins, and improve valve function, to enhance the effectiveness of the muscle pump, increase the rate of fluid flow in superficial and deep veins, to ensure the direction of that flow from distal to proximal, to close the capillaries and scars to reduce the fibroblast activity, provide pressure to damaged skin to facilitate the reorientation of collagen fibers in a uniform pattern in the case of hypertrophic and keloid scarring, and to correct posture, to provide support, and to provide sensory stimulation. Now, when we look at those are sort of the overall aims of compression, regardless of the clinical context, but we could be using compression for any or all of those. So where does this intersect with multi-trauma? Well, pretty much everywhere. And in fact, you could actually argue that the reducing dilated veins, improving the effectiveness of the muscle pump and increasing the rate of fluid flow may also apply in multi-trauma. So multi-trauma, we're asking a lot from compression in that we are asking it to do more than one address one specific need. So by comparison, in the case of lymphedema, primary purpose is managing the lymphedema, controlling the lymphedema. It's not a lot of we don't need to necessarily provide pressure to damage skin, or we're not necessarily trying to correct posture, but with multi-trauma, we might be actually ticking all those boxes. So now, just a loose definition of multi-trauma. As I say, it is not academically rigorous, but a practical sort of agreement between us as we look at this today. But multi-trauma often involves extensive soft tissue damage, orthopedic injuries, very frequent, oftentimes surgical interventions required. Sometimes actually the trauma can be it is mainly surgical intervention. Lymphatic compromise is not uncommon with multi-trauma patients. And then we may have factors like external fixators that are remaining in place for a period of time. So very quick overview again of compression garment construction, and just thinking about how this relates in the area of multi-trauma. So circular knit garments, and they are our most common readily available ready-to-wear garments. There is the possibility that this can be used in multi-trauma. It is not. It is possible that that it is not inappropriate. That's a sort of, sorry about the double negative, but it's not inappropriate from a clinical application to use a circular knit garment, which is the majority of ready-to-wear garments. Because we are not necessarily seeing the extremes of disproportion, or the lobular tissue that we may see with some edemas or lymphedema. However, what often precludes the use of ready-to-wear circular knit garments is actually the changes in shape as a result of the trauma itself, either significant wasting, defects, flaps, distortion of tissue, and so people often don't fit in ready-to-wear sizing. So an alternative garment is a flat knit garment, and there are some instances where a flat knit garment could be useful for multi-trauma, but these are the garments that are commonly used with significant lymphedema, and one of the limitations for using a flat knit garment, even if it's custom made for multi-trauma, is that it is limited in the way you can modify a garment. For example, a flat knit garment, you can't really, a lot of manufacturers won't permit the garment go below the B1 measure on the lower limb. And so if you have, and in fact, we've got a case in point, one of our case studies shows a flap over the ankle. So if you've got a very large area around the ankle and then very narrow above the ankle, if you can't take a zip into the foot, you can't, that garment, you can't get the garment on or off. So this is kind of where cut and sew garments really do come into their own, and obviously Jobskin is a cut and sew garment. One of the real strengths is the variability that can be accommodated. There's no clinical contraindications for the way the garment's constructed or the fabric that is used, but then it comes back to us as the clinicians to make good choices about the garment design. And these garments and these garment prescriptions can be very challenging, but I've got to say they are incredibly satisfying when you get a good garment, and they're also the sort of garment that require a lot of the patient input. So it really is a true team effort. As I'm not sure if I've mentioned already in this webinar, I did in the last, that Veronica and I as the clinical advisors and the design team do love a good collaborative challenge, and it's really great that we work together with the patient to provide something that's really what they need. So quick overview about Jobskin. Jobskin garments can be made for anywhere on the body, and They can be made of varying weights of fabric, and there's a couple of different types of fabric. We generally use Power Net, which is lighter weight, and Power Tex, which is a kind of got a bit more oomph behind it and is a little bit more durable. It's particularly good for higher levels of compression in the lower limb. As I mentioned just before, we really do encourage you to collaborate with us and with the designers. The designers are really happy to speak to you. It's not, you don't have to go through us, and you don't have to go through any intermediary. They're really happy to chat with you. And the fact that Jobskin offers so many options and modifications really allows for an accurate fit for varying shapes and sizes, addressing donning issues, being able to accommodate patient preferences, having a whole range of colour and style choice, varying levels of compression, and that can vary within the garment, not just graduated compression, but you can choose that one leg is one level of compression and the other leg is a different level of compression. We can target specific areas with compression. We can certainly include linings to protect friable skin. And also, this is particularly useful for scar management. And, with retrospect, it might have been a good idea for me to include something specifically about Cylon-Tex in this particular webinar. But Cylon-Tex is a silicone lining that can be stitched into the garment, and it does last the life of the garment. When I first saw it, I just thought, oh, why would I stitch silicone in when silicone lasts 4 to 6 weeks when you think of something like silicone sheeting. But in fact, it does last the life of the garment. It's far less of a burden on the patient, and it's really great for things like small areas like fingers and toes and hard to reach areas, or hard areas that are hard to kind of tuck silicone sheeting into and onto. And then, of course, when we're able to sort of line up the ducts like that, where we're accommodating preferences, it's a good fit, it's clinically effective, then undoubtedly we're going to get improved compliance from the patient. So let's just think about the practical impact of multi-trauma injuries for compression. What is it that we did allude to this at the start, but what are we trying to accommodate? Well, we often have to deal with grossly misshapen tissues. Oftentimes defects, significant defects in limbs or on torsos. And sometimes the usual anchorage points just are not there anymore, either because they are part of a defect, or there's been flaps there, or there's significant wastage, or extensive bony deformity, or injury or bony deformity. We're often trying to address extensive scar management needs. And then we're juggling sometimes needs of whether do we intervene in the acute phase as this garment for acute management, or are we looking at longer term compression? Maybe there's the impact of acute edema, which is going to hang around for a while, and so we can't just defer a garment indefinitely. Or are we looking at the onset of lymphedema, which is not uncommon? And from my observation, over a lot of years, I think that lymphedema in multi-trauma and with some scarring often goes unrecognised, because there's so many other kind of neon lights flashing in your face about soft tissue changes and defect and function and bony deformities, and that actually the fact that lymphedema has become established and it's not actually acute edema. We now are dealing with lymphedema, which has slightly different demands. I think often that goes unnoticed. And I did say on the last webinar, and I'll say again now, one thing I do notice is that commonly, not only is the onset of lymphedema, it's not picked up early enough because we're just not looking in some instances, but also when there's so many competing demands, I think in getting started on scar management is often deferred or delayed, or it just doesn't actually get onto clinicians' radar. And if for everything that we do for managing a multi-trauma patient is about good survival and good survivorship. And so we need to be dealing with issues like scar management and the onset of lymphedema as early as possible. All right, so now let's just think about, how do you measure some of these complex patients? The first thing I would say is just plan and prepare for it, because sometimes some of these measurements just feel incredibly overwhelming because they can be really extensive in injuries. So just like almost want to say, just stop and breathe and plan for it. Then most places have clinical records. Clinical photographs as part of their medical records. So refer to the photographs and actually look carefully at what the areas are that you need to apply compression to. And then based on that information, select the ideal base garment. There's no such thing as a base garment per se. I'm just using that as a term because we're starting somewhere. So are we looking at an arm sleeve, or are we looking at an arm sleeve with a glove, or are we looking at a gauntlet with an arm sleeve, or are we looking at waist-high tights or knee-high socks, or do we need to segment the garment? Just actually think about what it is that we want to measure for, and then you can obviously get the relevant measuring forms. And if you're not sure, if you're concerned that you don't know whether compression's achievable, or don't hesitate to give the clinical advisors would be the best port of call if you're actually not sure about how you're talking about the clinical application, not the practical achievability of it. But when we're getting more into that territory, do involve the designers, because as I said, they're really happy to help. For limbs, we do as we do for every other measuring for any other garment on a limb. We use the paper tapes. If you're not familiar with the Jobskin paper tapes, on our website, there's a whole series of measuring videos that show you. There's an introductory one that introduces the measuring system, and then there's some for all body parts, so you can feel confident before you actually tackle a real patient. You can get some paper tapes and go home and practice on children, loved ones, pets, so that you feel confident manipulating them. For some of the more complex scenarios like amputations, we might request some additional, or we do request some additional paper tape measures. And for amputations, there is a specific stump measuring video. It's only a couple of minutes long, but it shows you how we take those additional measures. Then for the measurements that we don't use the paper tape from, the ones that we use a retractable tape, that's usually the head and the torso. We measure the usual landmark points. But where you've got significant changes in shape, for example, if you're measuring for so let's say bike shorts, take a measurement at the waist, take a measurement at the biggest point of the hips, and you take a measurement midway between them. Now, if you have significant changes of shape and proportion over that kind of part of the body, the lower torso, take an extra measure in between the waist and the midpoint, and then between the midpoint and the largest point of the buttocks, and just write that in the comments section. And it's a really good idea to take photographs with the paper tapes in situ on limbs, or if you've got a tricky part of a torso that you're measuring, put the tape measure on and take a photograph with the tape measure on. It's absolutely invaluable information for the designers. I was helping a therapist earlier in the week to measure a garment for somebody who had a stoma, a suprapubic catheter, unstable pelvic fractures, significant defect over his buttocks, so that he had skin grafting to bone, unable to stand because he had no voluntary movement of his lower limbs. And when you look at this, you just think, wow, I just don't know where to start. But actually, when we stopped and kind of drilled it down, he just needed bike shorts. But he needed bike shorts with modifications. We needed to accommodate the stoma. We needed to accommodate the suprapubic catheter. We needed to take some extra torso measurements because he had a significant area of bulging tissue on one hip. We needed to take those measurements by rolling him in bed. So there was, so that was kind of, it's not as simple as taking the measurements in standing, but actually when we really got down to brass tacks, that was pretty much the only modifications that we were making in our process. We still took paper tape measures, we still took tape measure tapes around the torso, and one of the beauties, I have to say, of the Jobskin measuring system is that the paper take all the length measures for you. And torso measures generally don't require a huge number of length measures, so it's quite an intuitive measuring system. So it does make the measuring a little bit less arduous, I suppose, or challenging when you are taking some of these complex measures. Oh, and actually just one little aside, what we decided to do for this particular pair of bike shorts is that we're going to put zips from waist right down to the end of the garment of the bike shorts bilaterally. We're joking that they're kind of like stripper pants because you can just unzip the sides and then just lift them off. And that's really because this person is unable to stand. And so we need to tuck the garment underneath, then lift it through the crotch and then zip up the side. So actually that's a very simple modification, and it's really, they're still only bike shorts, but the whole donning mechanism is slightly different. And then my last tip about measuring multi-trauma is to use plastic sheeting for trace defects. If you're in a hospital, you could use a sliding sheet, or you can use a large snap lock bag that you cut open, because when you are trying to shape, if you're requesting a piece of memory foam to fill a defect, you can wrap almost circumferentially around a leg. That's one of our case studies that shows that. And you can trace around the shape of the defect, then transfer that shaping onto paper. Like in this particular case, we put the plastic, that we cut out the plastic after we'd drawn around the shape and then traced around it onto A4 paper. It went across 2 A4 sheets. So we just attached that to the order so that the designers could then put the 2 sheets together and had a very good visual outline of the memory foam insert that was required. So let's move on to the case studies. And I'm aware that there's Carrie that you have to go shortly, so we'll see what we can fit in. The first case study, these are kind of more, these are later photos. Unfortunately, I don't have any acute photos for this person, but this person sustained a high voltage electrical injury and so needed a free flap reconstruction with split skin grafts. If you can see, that's mature split skin graft scarring on the medial upper arm, and then the lower arm is a free flap, which from memory I think it was a gracilis flap that he had. So he was actually, there was a couple of different trials for garments for him. He was initially put into a forearm length garment because there was concern about going across the wrist and the elbow, but in fact, and with a recognition that he needed compression on the upper arm, but he was fairly quickly actually moved into a full length arm sleeve. And I apologise that the details are harder to see when it's a black garment, but it's a popular choice. But what we were trying to achieve with this particular gentleman was we wanted scar management for the split skin grafts. We wanted to shape the free flap. We also wanted to make sure that the garment didn't obstruct hand therapy, that it in fact supported hand therapy, and ultimately was going to enable him to return to work. And then a subsequent garment, it was modified slightly to change the positioning of the thumb. You can see that actually the thumb is sitting quite laterally, and he had no voluntary thumb movement after this accident. So the decision was made to go for a thinner eminence-free construction for the thumb. So the thumb did sit laterally to get better compression across the flap on the palm. And then a subsequent garment the thenar eminence shaping was restored because he had undergone a tendon transfer to for opposition. So it's like the early work was done on the flap on the palm, but then the priority for the garment then became my battery is getting a little bit low on my computer. So it's just gone a little bit fainter. I hope that's okay. Okay, we're just kind of going to kick on. And the one thing I would say is to highlight there is that the zip goes from just from the back of the hand to the elbow. And so it's not a full length zip. You don't always have to take a zip up to the top of a garment. It can be much easier to put on when it's inserted into the garment. All right, now this is not really a case study per se, it's really a case study vignette, and this is a garment that was just fitted this week, so I just dropped this photo in. I'm going to be quick because I'm a bit worried about my computer battery, and unfortunately, even though I raced home, my computer cord was not to be found because we've got some renovations going on, so bear with me. But this particular woman kindly consented for her image to be used. She had had surgical repair of previous scarring on the décolletage, just under where you see that quite rigid square of rectangle of elastic. And this is a really tricky area to get compression. The sternal strap can be stitched into a vest when a patient has a vest, or this one is a freestanding one, obviously. So we modified the garment design slightly to get this reinforced bit of elastic. And it so happens that I spoke to this young woman on the phone this morning. She was going, that compression is just amazing. My scar, when I woke up in the morning, was completely flat. Now, it's not going to stay flat, unless that compression stays in place. But I just thought that was such a beautiful example of how targeted compression can be achieved through some slight alterations to garment design. Okay, third case study. This isn't really a true multi-trauma patient at all, but shows what we can achieve through modifications. This was an elderly woman who had right upper limb lymphedema following breast cancer, and she had been wearing a flat net garment for 2 years. However, no, not 2 years, for many years, but then she fell and fractured her humerus. So she had acute edema. She had to go into Samiento brace to treat the humeral fracture, but there's absolutely no way that she could get a flat net garment on. So the therapist who was treating her opted to put her into a Jobskin garment with some modifications. She had silicone-backed elastic at the top to help with anchorage. She had a posterior zip because that was going to be more comfortable with the Samiento brace, and zip fastening aids to hold the two sides of the zip together while the zip was done up, which really did make obviously, when you're putting a garment on where there's a humeral fracture, unhealed humeral fracture, you don't want to dislodge or displace it in any way. So this kind of held things stably while the zip could be done up. Anterior elbow lining, as she was needing to use a collar and cuff, so her elbow was flexed all the time. And I think I mentioned already she had silicone-backed elastic at the top for anchorage. So as I say, it's not a multi-trauma situation, but it does give you an indication about how you can play around with some of the garments to accommodate the sorts of needs that you can see when there's like underlying orthopedic injuries. Okay, this last one, this is our bigger case study. A 34-year-old man lives with his wife and 2 children, owned his own business, very kindly consented for us to use these images. He had a high voltage electrical burn to his left leg, right hand, left arm, left flank, and buttock. Of interest is the fact that in his past medical history, he suffered from gigantism, which meant that his toes were enlarged, and he had toes amputated bilaterally for functional benefit and particularly to be able to fit his feet into shoes. Now, when he came in through emergency, he had to have a fasciotomy to the left lower leg, an escharotomy to the thigh, and then escharotomies for lower leg and thigh on the right, and also escharotomies to the middle ring and little fingers of his right hand. Unfortunately, it was deemed that the tissue on the lower leg, that where there'd been the fasciotomy, was not going to be viable, and so he had to have a through knee amputation. And I might add that he was in grave danger of having amputation to his right lower leg as well. However, you'll see subsequently about what the surgeon did, which enabled him to keep his leg. So he had debridement and skin grafts to all wounds. However, a month later, there were areas that it was clear that they were not going to be viable without further surgical intervention. And so he had a anterolateral thigh fasciocutaneous flap to his right hand, and that flap went across the middle ring and little fingers. He also had a thoracodorsal artery perforator free flap to his right ankle. And I should just say, for any of these clinical images, don't take any screenshots or take any photographs, because obviously patients have consented for these images to be used, which is very gracious of them and very kind. Now, I'm just going to step aside from this case study for a minute, just to talk about compression on free flaps. Certainly the units that I have been involved with or worked in really don't have established protocols for compression on flaps, and there's increasing numbers of flaps being done, and so I think units around the country are probably considering their protocols for this, and so there will be variability, and obviously surgeons will have different preferences for the timing. But if we think about what a compression can achieve for a flap, because you may have instances where you are choosing to advocate for the patient because you can see the benefits of the free flap, but that a surgeon may, up until that point, not considered compression. What we're able to achieve with compression on flaps is modulate the scarring, avoid tightening and pin cushioning. And pin cushioning is when a circular scar, which is obviously what surrounds a free flap because it's attached, it might not be a circle, might be an oval or a funny shape, but the scar is the suture line is continuous all the way around, so it forms a circular scar. If that tightens and contracts, it's a little bit like squeezing a water balloon and there's a bulge up the top. And because if the scar tightens, then the soft tissue of the flap bulges up, and it results in what we call a pin cushion, because it looks like a pin cushion. So we want to avoid that. We want to compress the fatty tissue because that will give us a better profile. We want to protect and normalize this tissue. We want to avoid fluid accumulation. We definitely want to assist with comfort and reduce dependency pain, particularly in the lower limb. There is the chance that we can avoid subsequent liposuction to thin the flap, and there is the chance that we can avoid neuropathic pain, and we can certainly control edema. So back to our case study. This is the gentleman. This shows the measuring of the lower limb, and he was measured at about week 3 for his, actually, no, I think he was measured about week 2 for his compression garments, and they were applied about week 4. So it's helpful to have photographs without the tapes in place so that you can see the actual shape of the flap, but then it was very helpful to have photographs of the tapes in situ so you can see where that flap is located in reference to the central spine of the tape, and also where it sits, where it's aligned with the circumferential tapes. So he ended up going into a knee-high sock with a lateral zip. Again, it's black, of course, so it's hard to see, but you can see what a remarkable gain has been made in shaping for that gentleman. His foot looks a bit unusual because he'd previously had amputations of toes because of the gigantism, but you can see on the right-hand side of that foot, there is almost a normal profile for that tissue where that flap has been. And so he had a zip that went down just behind the I think I said lateral before. That's the medial side where the flap was. I apologize. But he had a zip that went down the lateral side of the garment behind the malleolus and sort of just went into the beginning of the foot so that he could get that garment on safely and that there was no risk to the flap in the early period of time. And then the garment for his right hand, that flap this injury was incurred in December of last year. That flap is still joins the ring, middle, and little fingers together, but it will be subsequently divided, and so he'll be able to go into a glove at that point. But he's wearing sort of almost like a cross between a glove and a mitten. But because he's very active and adept, subsequent garments we ordered with the leather reinforcement so that he could really do whatever he needs to do and is able to do with that hand. So that's been added just for durability. But you can see, I mean, this is such a beautiful example of what you can achieve with compression over flaps. And our last case study is a young woman who was unfortunately hit by a car. She had complex fractures in both femurs, and you actually can't see in this photo, but she had significant, she had pin site scarring actually from an external fixation in her left thigh, but her right thigh, she had extensive soft tissue loss. She also had pelvic fractures. She was not referred for scar management for almost a year, and she's a good example of someone who actually should have been seen way, way, way earlier for scar management. So some of the scarring was mature, but she had had extensive debridement and split skin grafts into that area of defect. So she needed a memory foam insert, and she's a very good example of someone who can be measured using that plastic sheeting I spoke about at the start. So she had plastic wrapped around her thigh because it's almost impossible to try and measure the shape of sort of an unusual defect, particularly when it wraps around almost circumferentially and when there's a change in gradient. Obviously, the shape closer to her knee is far less than the shape of her thigh. So we traced with plastic and then put that onto A4 paper and sent that through. And she wore these capri pants for a considerable period of time. Now, what you're achieving when you've got a memory foam insert is that you then get this transfer of the compression through the memory foam onto the scarring that needs it. Because if you don't fill up that defect, you'll get compression everywhere except on the skin grafts. And everywhere is not bad in terms of managing edema and helping with some tissue shaping sort of around the defect. But there is the risk that you can get pressure breakdown right on the borders of the defect because they're getting extreme pressure there. And also you're not achieving anywhere near what you could or want to be achieving. So that memory foam defect basically makes it all work together. All right, and just a quick note about external fixation. This patient doesn't have external fixation, but unfortunately I didn't have an image, but I just thought this was a good example to show you. If you imagine on that leg there was an external fixator with pin sites there, you can see the way that tape is wrapped around the leg, that actually that gives you a very accurate indicator of where the pin sites are. If you tuck the spine of the tape under the external fixator and then you wrap around the limb, you can see, because there's marks all the way along the tape measure, obviously, we get the height that the pin site is by the spine there, and then we get how far it is away from the spine through all those little markings along the tape measure. So photographs, external fixator in place with the paper tapes in place are extremely useful. Very quickly, just to finish up. Yeah. Thanks for being here, Carrie. See you.
See ya. Thank you.
Just to finish up, when you are ordering, you need to include an order form plus the relevant measuring form that you've used. you then send that order to customer.service@jobskin.com, regardless of whether you're in Australia or New Zealand. The factory number is 0399158000 for Australians, and I apologise, I forgot to put on the New Zealand number, but Veronica will put that in the chat. And then I've been told since the last webinar that I've got the incorrect number up there for the design team at the bottom of the page. It should be 8010. So if you can just make a note of that. But what I would say to you is we really do aim to resource you well to do your job. And so there's a lot of resources under the support and training tab. There's measuring videos, there's previous webinars, there's lit reviews, there's past newsletters that have got ideas and kind of upskilling in them. And as always, Veronica and I are here to support you in your clinical role, as are the designers who are on that number at the bottom of the screen, except change it to 8010. I think we've probably got time for a few questions if anyone has any questions that they would like to ask. You can either unmute and just ask them, or you can type them into the chat and Veronica can read them out. Just while we're waiting, I'm just thinking in the last chat, the last webinar in the chat, there was a question about protocols for compression for flaps, because as yet there isn't a lot of published information about it, and so generally each unit, I'm sure, is developing or may have developed their protocols. But someone has just asked. There was a paper at the Burns conference that we were involved with that does, I think from memory, I think there was a bit more information about the protocols there. I can't quite remember, but what I can say is that the unit that I was working in, where that paper originated, was we would have compression on free flaps by week 4, possibly week 3, but obviously the surgeon has a very significant say in that, and the garment needs to be safe to don, and the obviously established blood supply to the flap, and no risk of shearing with donning and doffing. Back to you, Veronica.
See you later, Helen.
Thanks, Helen. Thanks for being here.
I was just going to say, while we wait for any further questions to come through, many of you will have registered for the webinar. Some of you might not have. Absolutely not a problem. If we don't have your email address and you'd like a certificate, can you just send me through an email in the chat? I've just popped my email address, or alternatively, you can pop your email address in the chat, and I will make a note of that to be able to send you a certificate.
Cool. I don't think there's any questions.
Okay.
Thank you all for joining us for the webinar. We hope to see you for future webinars, and please visit our website as well as our YouTube channel for other resources, and we'll see you guys next time. Take care.